specifics of disorders, building on what we talked about last week. We're going to look a little bit more at the blood vessels in the central nervous system and what happens when they go bad. Alright. So when we're looking at the blood flow going into the brain, a quick review of the vessels that are supplying the brain. So you've got your main carotid arteries coming off here, and it will branch to the internal and external carotid artery. External carotid is very important for the face and for the scalp, but when it comes to brain tissue, it's the internal carotid where it branches off right here, where we go, right here at the angle of the jawbone here. It's about there that we've got the branch off. Then we have the two internal carotids that come in, one from either side, to supply the most of the anterior portion of the brain. Then off the back, coming off of this subclavian artery here, is we've got the vertebral arteries. They're called the vertebral arteries because they kind of come in and snake through the vertebral bodies here before they come into the brain to dump up their blood. So if we were to flip the brain over and look at it top side down, we have our little circle of Willis. So circle of Willis is where these four arteries have connections. So the vertebral arteries towards the back, the posterior circulation, that's why this is kind of in a different color, this reddish color. You've got our two vertebral arteries coming together to form the basilar artery, and the basilar artery comes forward and mostly supplies this posterior cerebral artery. So these are considered the posterior circulation. Then the larger the larger internal carotids come in, and they supply the anterior cerebral artery and the middle cerebral artery, and these big arteries are considered the anterior portion of the circulation. Now, a nice little thing that evolution did for us is that it created this circle of Willis. The circle is a connection between all four of those arteries. Now, ideally, all four of those arteries are wide open, supplying lots of blood, and we don't have many issues. But we know a lot of times things happen like carotid atherosclerosis. This is why we listen for bruits over the artery, the carotid artery. You can have someone who's got one of their carotid arteries that's completely blocked or almost completely blocked, but not really have too many or sometimes no neurologic symptoms because the other three vessels are still open and able to supply blood. And when it comes up to this circle of Willis, those other vessels are able to take over and distribute blood throughout there. So the circle of Willis is very nice for us. And remember when we talked about our venous system, veins are actually in the sinuses. We call them sinuses in the brain. They're in between the two layers of the dura mater. And they don't have any valves. The venous system in the head relies on gravity. One of the reasons you start to feel really congested if you stand on your head for a while or have your head upside down for a while is that we don't have valves, so venous blood tends to pool, which then pushes pressure back on the arterial side. So here's another picture looking upside down once again at the circle of Willis. We've got our two vertebral arteries coming up the back, joining to form the basilar artery, like right at the base of the brainstem. And then we've got our circle of Willis here, our internal carotids coming in right here with our middle cerebral artery. See how large that middle cerebral artery is, how it's pretty much a direct branch off of that internal carotid. And then our anterior cerebral artery up here. So you really should know that we've got those four vessels that are coming in, the two internal carotids, the two vertebrals that form the basilar. And that off of those, our biggest vessels, we've got a posterior cerebral artery, which is considered part of that posterior circulation, the two vertebrals, the basilar posterior cerebral artery. And then we've got our anterior circulation, which is the internals supplying both the anterior and middle cerebral arteries. And I just got picture crazy. I'd like to have lots of pictures, they're pretty. Okay, and then remembering once again where our venous sinuses are and the little villi that pop in and allow us to drain cerebrospinal fluid. Wow, I put a lot of pictures in. Okay, here's a different view of the pictures. And I actually was searching like a video to show you like 3D where the vessels are, and I couldn't find a really good one that was either brief enough or didn't have a really annoying narrator. So, oh well, you get the basic idea. Okay, so a couple of concepts to look at. First off is autoregulation. Autoregulation refers to the ability of the brain, well, the blood vessels within the brain, to maintain a relatively constant cerebral blood flow even when we have changes in arterial blood pressure. And it will do so by doing some vasoconstriction and vasodilation to keep the blood pressure, the blood flow, and therefore the blood pressure steady throughout the central nervous system, even if we have pretty large fluctuations. Now, it can't overcome a shock situation, but we can do some constriction or dilation to make sure that the brain is protected in times of stress. It also refers to the fact that there's little areas of vasodilation and vasoconstriction in response to smaller areas within the brain that are more metabolically active at a given time and therefore more in need of blood flow at a given time. So what's going to affect this? What's going to cause vessels to vasodilate or vasoconstrict in a tiny area? When you think about these, they should make sense. Number one, carbon dioxide. If there's a localized increase of carbon dioxide in the area, it will cause the cerebral vessels, the smaller cerebral vessels right in that area, to dilate. Carbon dioxide is a byproduct of cellular metabolism. So if you have more carbon dioxide in the area, that means the cells are more active, indirectly. So that means, hey, I probably need to get more blood here. Hydrogen ion concentrations. An increase in hydrogen ion concentration causes an increase in blood flow once again, more vasodilation. And hydrogen ions are a byproduct of anaerobic metabolism, definitely letting the vessels know, hey, we're going to need some more blood in this area. And oxygen concentration. When we have decreased oxygen in an area, it's also going to cause vasodilation. So you should make sense when you really think about them, that they are working together to indicate, hey, cells are working more, we need to increase our localized blood flow. So even though we have the sympathetic nervous system innervating our blood vessels in the central nervous system, there's so much tiny localized stuff going on helping to adjust regional blood flow second by second that it's really only important when our local mechanisms start to fail, meaning we have something going on with the body that's pathologic. So most of the time, brain takes care of itself, sympathetic nervous system doesn't really need to get involved. All right. Stroke, also seen as a CVA or a cerebrovascular accident in medical charting. This is brain damage caused by causing a neurological deficit due to a blockage or cessation of adequate blood flow to an area. This is a huge cause of morbidity and mortality around the world and in the United States. About 700,000 Americans are afflicted each year with a new stroke, and a lot of people do survive but have long-term consequences as a result of strokes. It's the third leading cause of death in the United States. And we do have two broad types that we're going to talk more about, ischemic and hemorrhagic. Our risk factors for stroke are categorized in two areas, non-modifiable and modifiable. Non-modifiable, we can't really do anything about it. So one is age. Your risk doubles every decade that you are over 55 years of age. No matter what else you've got going on in your life, your risk is going to double every decade after 55. Family history, can't change your genes yet. Race. African Americans have a much higher incidence of morbidity and mortality. Very complex. There's a lot of the issues that go back to inequalities of healthcare, some genetic underpinnings, higher rates of hypertension, obesity, and diabetes. The gender incidence is higher in men, but the mortality is higher than women, meaning that more men have strokes, but proportionally more women die of them. And a lot of it goes back to what we talked about last semester, that when, traditionally, until recent years, when research was done, it was more frequently done on men, and then applied to women, assuming that women would respond the same way as men. And we have found out that that's not always the case. A prior TIA, don't know what a TIA is yet, maybe, but we'll talk about that later in this lecture, or a stroke or an MI or heart attack. So basically it comes down to the idea that there's nothing inherent about a stroke that will make you have another stroke per se. But we use the saying, if the pipes are bad in the basement, then they're bad in the attic. Meaning that you don't get atherosclerosis in one spot. And if you've had a heart attack due to atherosclerosis, it probably means you have atherosclerosis throughout your blood vessels to varying degrees. So it just indicates this is all cardiovascular, including cerebrovascular. So we know that there's something underlying. You've had, for whatever reason, hypertension, hyperlipidemia, diabetes, other things that have led to the incidence of a stroke developing. So now our modifiable risk factors. Modifiable risk factors are things that we can do something about. So these are the ones that we really focus our interventions on. And number one, and in capital letters, is hypertension. Hypertension is the single biggest modifiable risk factor for all types of strokes. In fact, if we could get rid of hypertension, if we can get everyone to control their hypertension, take their medications, do the lifestyle changes, we could cut stroke rates in half by about 50% or so. And that's significant to have one risk factor for a multifactorial disease, that you can just take away one of those risk factors and have such a huge impact. So this is one of the reasons why we have now that whole category of pre-hypertension, which didn't exist until a couple of years ago, saying, hey, if you're starting to creep up, we need to start paying attention now waiting until it gets too bad. Smoking, so there's going to be a lot of overlap with the cardiovascular stuff. Diabetes, so we can maybe not get rid of diabetes, but we can control diabetes, control blood glucose levels. Carotid or other artery disease. If we note that we have a bruit, we can undergo further testing. One of the big issues with a cardiac bruit, meaning cardiac atherosclerosis, is that a piece of that plaque could break free that's lodged in the, sitting there on the side of the wall of the carotids, can break free and then travel north and cause a blockage, which would be a stroke. So if we can identify patients, there are ways, both medically and surgically, but surgically is pretty intense. Carotid endarterectomy it's called, where they actually go in, open up the carotid, pull out plaques, and reclose everything up. But I think you can imagine it's pretty risky opening up a large blood vessel that's supplying a big portion of the blood to the brain. Atrial fibrillation or other dysrhythmia, once again, may not be able to completely get rid of it, but we can control it with medications and with things like pacemakers. Cardiac valvular disease, sickle cell disease, same idea. Can't necessarily cure it, but we can control it. Cholesterol, diet, physical activity, alcohol, small amounts of alcohol, lower doses of alcohol, 1 drink a day for women, 1 to 2 drinks for women, 2 to 3 drinks a day for men is cardioprotective, but anything beyond that is going to cause some issues. And then drug abuse, especially cocaine or other stimulants, cause huge temporary increases in blood pressure. So we will see sometimes over on our neuro unit a patient who's 30 with no comorbidities except they snorted some cocaine and then ruptured a blood vessel in their brain because their blood pressure went up so high in the period right after that they took it. So just say no to drugs. Okay. All right, transient ischemic attack, or TIA. This is basically brain angina. It's the same kind of idea, whereas that we have an area that is narrowed, maybe there's severe atherosclerotic plaque, and the same kind of things that can cause angina, which is pain secondary to not enough blood flow, can cause a TIA, which is neurological symptoms secondary to not enough blood flow. Now the brain itself, brain tissue does not have nerve endings as for pain. So you're not going to feel pain necessarily from ischemia the same way that you would in the heart. You can have pain from cerebral edema that develops afterwards, but you won't have necessarily pain from ischemia. But it's neurological conditions, neurological symptoms or deficits that last for less than 24 hours. So we have basically a temporary decrease in blood flow because of a partial blockage that is able to clear, or the symptoms stop as regional brain activity in that area slows down and the brain is able to catch up. But it's a big warning sign that something is going on. Good indication that you are headed towards maybe having a large stroke. So we really want to encourage any patients who have risk factors for strokes or have had a previous stroke, have very clear education about, what kind of symptoms you may see with a stroke, and that you should come to the hospital immediately, because people will ignore things for a very long time, some of them. So this zone of penumbra without central infarction, that doesn't make sense yet, but we're going to get to what those penumbra and central infarction mean in a couple slides, and then when you go back over this, you go, oh, okay, I get it, hopefully. So ischemic stroke. Ischemic stroke we can separate into two categories. We have thrombotic or embolic. And you already know what a thrombus or an embolus is, so we're just applying it to central nervous system vasculature. So thrombotic is a clot that's forming right at that spot. So it could be due to the rupture of an atherosclerotic plaque, just like with the heart attack. It can be because of a hypercoagulation disorder in absence or in conjunction with some atherosclerosis, so something like sickle cell disease or polycythemia. Can be due to hypertension that has underlying caused a lot of that atherosclerosis, okay? So we'll put that hypertension in there to emphasize what a big role hypertension has in all types of stroke. Embolic, it's usually a cardiac source. So if someone comes in with a stroke that is an ischemic stroke, now we categorize these based on, is it a thrombus right at the spot or an embolus from somewhere else? Sometimes we never know for sure which actually happened. These are sometimes just theoretical categories, because once the clot happens, where did it come from, we're not exactly sure, sometimes. But because of that, what we're going to do for any person who comes in with a new ischemic stroke is we're going to do a full cardiac workup. Because so many of the times, an embolic stroke, so something that came from somewhere else, is due to something that's going on in the heart. So you can have a mural thrombi, meaning a clot that forms within the heart. Doesn't usually happen in a normal healthy heart, but if you have a heart with dysrhythmias or a heart that's had a heart attack where part of the muscle doesn't work right and you don't have that nice smooth contraction going on, you can have a clot that forms just like an atrial fibrillation, clot that forms because you don't have smooth flow, you have turbulent blood flow, and if that clot forms and a part or all of it breaks free, it can end up lots of places, including the central nervous system. Valve vegetations. Vegetations occur when you have endocarditis, when you have an infection of the lining of the heart. Luckily, something else that doesn't happen all too frequently nowadays between vaccines and antibiotics, but it does still happen, especially for patients who have high risk, like they're undergoing dialysis and getting exposed to a lot of germs, unfortunately, because they're getting needles stuck into them frequently. Patients who are IV drug users. So it's just chunks of bacteria and white blood cells that can break free from these infected valves, because the endocardial lining lines the valves too. Those valves are flopping around like this, and a piece of it breaks free. Atrial fibrillation. You guys know about atrial fibrillation. Atria doing this, so we might still have good cardiac output, but when the atria are fibrillating or fluttering, you're going to have smaller clots forming. And a lot of times with atrial fibrillation, we'll see something like someone with a decline in status, and not a huge stroke, but a whole bunch of teeny tiny little strokes that end up everywhere because they've made lots of teeny tiny clots that have flown out all over the place. Carotid artery plaques. So like we were talking about a few minutes ago, plaques that are in that carotid artery, pop them free. And once again, hypertension can be involved in pretty much all of those. So here we have a picture of our thrombotic stroke. So we've got some plaque forming, narrowing the artery, and this plaque either ruptures or in conjunction with a smaller clot that forms, we have a blockage. We've got all the blood behind it. Anything that this vessel was supplying is no longer getting blood. Embolic stroke, same outcome, it's just where did it come from? Now we don't have those plaques there, but we still have the big clot that came from somewhere else, or a chunk of vegetative material, or a piece of a plaque that came from somewhere else. and these vessels are not getting any more blood. Now, hemorrhagic stroke. Hemorrhagic stroke's a little different. Now, with a hemorrhagic stroke, we have a rupture of a blood vessel. This can be, hemorrhagic strokes tend to be a lot worse for a patient. If you're going to pick to have a stroke, which you usually wouldn't pick to have a stroke, but if you had to choose, I definitely pick an ischemic over a hemorrhagic every day. Because you have a double whammy now. You not only have the blood that was supposed to go this way going other places and usually ultimately compressing this vessel because there's all this blood leaking out where it shouldn't be, but now you have a lot bigger problem with edema and increase in the cranial pressure because we have blood going into places where it's not supposed to be. We don't have a ton of extra room in that cranial vault. So our hemorrhagic strokes in general tend to be a lot more severe and a lot more deadly than our ischemic strokes. So like I said, the hemorrhagic stroke is the most frequently fatal. You have a rupture of the blood vessel, which causes hemorrhage into the brain tissue, edema, compression, and something called vasospasm, which we'll talk about in a little bit. Our predisposing factors for this, specifically due to the hemorrhagic stroke, age, hypertension, and presence of an aneurysm that then ruptures, trauma, a tumor, or an arterial venous malformation or an AVM, which we will talk about during this lecture. These tend to be sudden and often with activity. So you've got an underlying weakness in a blood vessel, you're being more active, which is going to raise your blood pressure. Maybe you're under stress and it's raising your blood pressure, and then bleeding occurs. You can have it inside of the cerebral area. It can also be into the subarachnoid space, meaning between the layers of the meninges. All right, so promise you I'd come back to this, ischemic penumbra. Okay, so you've got either a clot or sometimes a rupture that then slows down and you've got a clot forming here, but either way, right here is our clot, okay? So right here is our blockage. And these cells right here that are kind of in the lighter gray, see those there? These cells are exclusively reliant on the blood flow from this vessel in order to survive. So these cells are going to die off very quickly. It's very hard to save these cells unless you happen to be at the hospital already and can be administered medications and treatment immediately. So those cells are unlikely to get back. However, so that's your infarction. Infarction, dead cells. Around here you have something that we call the penumbra. So that's kind of in a circle around there. So those cells were reliant mainly on this vessel. However, since they're a little bit farther away, there's other vessels with collateral flow that are close enough that some of the nutrients can seep over. It's usually not enough to keep these cells alive forever, or not very long even. Maybe 3-4 hours. But in those 3 or 4 hours, you can get to the hospital, get treatment, and potentially save these cells in the penumbra. Now what's going to happen is that the longer you wait, these cells need a lot more to live long term than the little bit they're getting from the collateral flow. And the more cells that start to die off, they're going to start to release glutamate. We're going to have issues with excitotoxicity. We're going to have more cells dying in the area. But these cells we potentially can save. If we just keep waiting and waiting, that infarction will grow, and that entire area where the penumbra was will just be one big infarction. We can't get any cells back. So normally what's happening in that penumbra is that we call them that they are in electrical failure, meaning that they don't have enough oxygen and nutrients, they don't have enough ATP to create action potentials. So if you were to test those cells, so say this was a motor neuron for my finger. This is a motor neuron telling my finger to move. I might not be able to move my finger even though these cells are still alive because they don't have enough energy to do what they normally do. However, if I get blood flow back to them, And then I can start moving my finger back. If I don't get blood flow back to them, I'll never move this finger again. Okay, so just a little overview of pictures, get a general idea of what large blood vessels, those vessels that we talked about at the beginning of the lecture. So anterior cerebral artery, we touched on this last week. Anterior cerebral artery is going to be kind of a mohawk down the center top. It goes up the front and then courses along the top of the head, top of the brain. Middle cerebral artery, once again, appreciate just how much of the brain is supplied by the middle cerebral artery. Then we have our posterior cerebral artery over here. Don't worry about the anterior choroidal. Now we're getting too nitty-gritty. But this lighter yellow as well as this darker yellow, which is just some different branches of the middle cerebral artery, this is all middle cerebral artery. And if we look at, here's looking at the brain from the outer aspect. Once again, you've got your middle cerebral artery from the outside. We have our little mohawk of the anterior cerebral artery, and then our posterior cerebral artery back here in the green. And here, if we cut the head down the middle centrally like this, here you can see more of the anterior cerebral artery that goes down the middle, posterior and middle cerebral artery. So, remember the homunculus? Have you seen this picture before? Homunculus meaning like tiny little man or something like that. Interestingly, I'm not sure we talked about this before, but I thought this was fascinating. A fair amount of people have a foot fetish, which I do not, especially in nursing, and you see what happens to feet as you get older. You're like, I never want to see another foot again, right? But it's theorized that potentially why is... They're talking about foot fetish. Got some mood music going on. Just look how close on the sensory cortex the feet are to the genitals. So they've theorized, and I mean it's funny, but it is, an actual theory, there's enough of a crossover of neurons in that area that some people are like, oh, feet. So this is the layout of the somatosensory cortex. This is the layout of our motor cortex. Pretty close overlap in general of things going on. A little bit slight difference in distribution, but overall pretty close. So just note that our anterior cerebral artery is going to supply our legs, whereas our middle cerebral artery is going to supply hands and face. All right, so anterior cerebral artery in text, what are some things we're going to be worried about? The medial aspects of the frontal lobe. Central symptoms are contralateral, because remember everything switches over, contralateral hemiparesis and sensory loss of the lower extremity. Okay, so remember it's lower extremity because of where it is on the homunculus, and it's going to be contralateral, so opposite side, because where our brains do all that little switching stuff. Also some problems with impaired cognition and decision making due to the areas of the frontal lobe right up here that are very important in things like cognition and decision making. Middle cerebral artery, it's the most common site. Yes?
Could you tell us what hemiparesis is?
Oh yeah, hemiparesis, partial paralysis or weakness. Thank you. Okay, middle cerebral artery is our most common site for a stroke. Part of the reason is because it's responsible for so much of the blood flow to the brain that it kind of has to have a higher percentage of strokes. Also, it is the main direct branch off of the internal carotid artery, so it's more likely that anything that breaks free is going to do a straight shot into that middle cerebral artery. So any of our embolic strokes are going to more likely go to the middle cerebral artery than anywhere else. We have our lateral cerebral hemispheres and our basal ganglia that are affected. So we have, once again, contralateral hemiplegia, more of not the leg, but the trunk, the arm, the face. contralateral sensory loss, aphasia, especially if it's on the left side. Now, your speech centers are usually lateralized to your dominant hemisphere. So if you are right-handed, like I am, and a lot of you are, your left side of your brain is your dominant hemisphere, and that means your speech center is lateralized to the left side. So if I had a stroke on my right side of my brain that affected my middle cerebral artery, I'd probably still retain most of my speaking abilities. To the left side of my brain, because it's probably lateralized because I'm right-handed, I probably have a lot more problems with aphasia because Wernicke's and Broca's areas are over there. Okay? So something that you'll see quite frequently that you don't see in other areas of adults or many other areas of adult health is that when you are talking about the history of a patient in the neurologic area, you'll often see, 76-year-old Caucasian right-handed male. We worry more about what's their right hand, what's their left hand, because we know that there's some things that are lateralized based on what hand is the dominant hand. Symptoms we talked about, we got to aphasia, and then something called neglect syndrome, which we'll talk about a little bit more towards the end of this lecture. Posterior cerebral artery, so it's occipital lobe and the medial aspects of our temporal lobe. So symptoms are going to be a whole bunch of vision issues, memory impairment, because in the medial aspects of the temporal lobe we have our hippocampus, and also some cranial nerve issues. Do you have a question, Joanne?
Yeah, what's hemiplegia?
Hemiplegia, what's the same thing? So hemiparesis, hemiplegia, just partial paralysis. Thank you for doing that, because I'm sure you're not the only one who had the question. All right, basilar and vertebral artery. Supply the thalamus, the cerebellum, and the brainstem. We can have some issues with sensory loss and mild weakness, not due to problems in the motor cortex. If you remember, we talked about last week, motor coordination of movement is lots of different areas of the brain. So this is more due to the fact that the thalamus is the relay center between upper and lower areas, and when the thalamus is affected, as it would be here, potentially, we can have problems just getting information back and forth. With disturbances of gait, speech, swallowing, and vision. And I'll let you read through this. You guys don't have to memorize this by any means, but just a little bit of difference that, we have some universalities. You injure a motor cortex either on the right side or the left side, whatever that area, you're going to have motor issues. With some of the less tangible things, like spatial perceptual deficits, denying or minimizing problems, that kind of thing, that's going to be a little bit different in right versus left brain. Don't need to memorize this. If you get into neuronursing, you can pick more up on this, but just understand that there's some more other subtle differences that can occur depending on whether it is the right side or the left side of the brain that is affected by a stroke. Yes?
You did say that if you're right-handed, then your left hemisphere is dominant?
Is the dominant one, yes. And that's where you'll usually find your speech, where your dominant speech center is lateralized to. Okay. Another smaller category of stroke is something called small vessel strokes or lacunar infarcts, sometimes called silent strokes. So what we have here, here's our middle cerebral artery. It kind of courses up diagonally and then is branching out as it's going from the circle of Willis up through the lateral aspect of the cerebral hemispheres. And then you've got all these little tiny vessels that are branching off, called penetrating arterioles, that branch off into the basal ganglia and some deeper areas of the hemispheres. Probably due to hypertension. I think I go to underlying causes on the next slide. But the reason they're called lacunar infarcts is it's little teeny tiny infarcts, and in the process of healing, these little cavities that you would see on a scan or on an autopsy. But you can pick up on something like an MRI. And lake in Latin is lacunae, so that's why it's called lacunar infarct. And you get a lot of relatively non-specific symptoms that accumulate over time. Oh, I didn't talk too much more about this. Okay, so let me just talk a little bit more for clarification. Usually due to hypertension, or there's a hypertension component where it's little ruptures of these vessels. We call them silent strokes because they're happening, they're small areas that are affected, and one of them is probably not going to leave a whole bunch of deficits in a person. But we'll have people, the general presentation is, if someone comes in, they're bringing in an elderly parent, and they've been falling a lot lately, and they have problems finding words, their memory isn't that great, and there's just something not right. And then we start doing some more tests and some more scans, and we say, no, there hasn't been one big stroke, but there's been lots of little underlying strokes. So once again, I'm going to try and find out if there's anything underlying that we can fix, like a dysrhythmia or hypertension, because we can stop them potentially from having more strokes, but at least at this point, we can't get brain tissue back once it's been destroyed. Yes?
How are these different from aneurysms?
So aneurysms are bulges in a vessel. We're going to talk more about specifically aneurysms in a few minutes. And they can rupture, but it is a bulge that is a weakness, and you can rupture without having aneurysms, and you can have an aneurysm without rupturing. So we'll clarify that when we talk about aneurysms in a couple slides. So pharmacological treatment. Now what we want to do, we have lots of stuff we can do pharmacologically when we're talking about prevention of disease processes or treating the modifiable risk factors, okay? But we're talking about specifically someone who's had a stroke. What can we do? I think you guys have talked about the clot busters last semester when you guys talked about heart attack. Maybe touched on them a little bit. Okay, so this is the same kind of medication that can be given to someone who's had a heart attack. They've got a clot that needs to be broken down. We can give something called tissue plasminogen activator, TPA. Altepace is one of the brand names, but TPA, tissue plasminogen activator, it's a chemical that our body makes itself, but usually in very small amounts in localized areas to break down clots as they get old. But we can use it pharmacologically to break down big clots. So it converts plasminogen to plasmin, which helps to essentially eat up, break down, digest the fibrin matrix of clots. So it is a really dangerous drug. We don't just be like, oh, you might have had a stroke, let me try some of this TPA and see if it works. Because when you give someone TPA, you are breaking down any clot that they currently have and preventing new clots from forming for a period of time. So we have very, very specific criteria because someone can hemorrhage, have another brain bleed if they haven't had one yet. It's not something that we just give willy-nilly. So here are some of our guidelines. The Stroke Council says that patients should be over the age of 18. Don't see too many strokes in younger kids, but it does happen. A hemorrhagic stroke must be ruled out by CT. That is one of the first things that's going to happen when someone comes in with a stroke, is that we want to get a CT. CTs aren't quite as good. CT CAT scan is not as good as an MRI as far as detail. But whereas an MRI can take an hour, a CT you can get really fast. So initially someone's going to get a head CT right away. And they're going to differentiate, is it an ischemic stroke or a hemorrhagic stroke, because they're very different treatments for someone who's had a hemorrhagic versus an ischemic stroke. So if we ruled out that they're bleeding, because if they're having a hemorrhagic stroke and we give them a clot buster, you're going to kill them. We must have some neurologic deficits present. Now if they say, oh, for an hour my arm, I couldn't move my arm at all, my vision was blurry, but now it's better. Well, that was a TIA. Giving them a clot buster is not going to save any cells that were already dying because they don't have deficits. So now we don't have any benefit to giving them this medication. Must be administered within 3 hours of symptom onset. Once we go past about 3 hours, some institutions are stretching it out to 4.5 hours. But once we get past a certain amount of time, 4.5 hours is about as far as they'll go. We now know that penumbra, that ischemic penumbra, has now become all ischemic tissue. We've moved past the point where we could have saved any of those cells. And therefore it makes no use for us to give the TPA because we're not going to save the cells, they've already died. So there is a very specific questioning that is done when someone comes in with a stroke symptoms to identify at what point did these symptoms start. Because if it was 12 hours ago, or if it is an unknown time, they won't give, like I found grandma down on the floor, I haven't seen her for a couple days, I don't know how long ago she had her stroke. They're not going to give it because the risk is just not worth it. Because our big risk is intracranial hemorrhage, but they can hemorrhage everywhere. Lots of different places. If they've had any recent surgery, we'll talk about contraindications, I think, on the next slide. Don't need to worry about the route and the dosage. Just know it's usually given in a couple boluses. It's not just all at once. So who cannot get it? Contraindications. You cannot get this if you have an intracranial hemorrhage going on. If you have any other kind of active intracranial bleeding. If your platelet count is really low. If you've had intracranial surgery, a serious head trauma, or a previous stroke within the last 3 months. If you have a history of intracranial hemorrhage. If your blood pressure is currently greater than 185/110 and we can't bring it down with using medications, or a known arteriovenous malformation or aneurysm. We're going to talk about those, I promise. So we're going to take the patient's history. Any of these are way too risky, and in general, the risks outweigh the benefits. Warnings, this is when we're like, when you really need to weigh out in an individual circumstance. Minor or rapidly improving symptoms may not be worth the risk. Major surgery trauma excluding head trauma in the previous 14 days. So I just happened to have colon surgery to remove a cancerous growth 10 days ago. You give me the TPA because now I had a stroke and now I start hemorrhaging from this surgical site that hasn't all the way healed yet. Any GI or urinary tract hemorrhage in the last 14 days. A recent arterial puncture or lumbar puncture where they've gone into either the artery or to the spinal cord to withdraw fluid. Abnormal blood glucose, we can work on correcting that in the meantime. Or a seizure at the time of the onset of the stroke. Those we know that the risks may outweigh the benefits. We need to carefully weigh our options. Okay, so on to an aneurysm. An aneurysm, I tell you, Tuesdays are rough, man. I talk all day long. A bulge at the site of a localized weakness in a muscle vessel wall, usually at a bifurcation. So you remember what bifurcations are, yeah? No. So where the bifurcation is where two vessels split. So here's a bifurcation here. Basilar artery comes and splits off to form these two posterior communicating arteries to join the circle of Willis. So that's a bifurcation right there. Here's another bifurcation right here. This is one of the big ones right here, is that first branch off once it gets to the middle cerebral artery. Another very common one, anterior cerebral artery. In between the two ones at the front, there's a little anterior communicating artery. Lots of aneurysms that tend to form here. Now, this is a congenital defect in the muscular layer of the artery. You are born with it if you have it. And in fact, they've done some brain scans. They did a study in England a couple years ago where they just said, hey, we want to just see what older people's vessels look like. And there was a lot more people than they expected who actually had aneurysms. Luckily, a lot of the times, in fact, probably most of the time, they don't rupture. And if they just stay small and they don't rupture, they don't really do anything. So some of you may be out there with a little aneurysm, or maybe have a predisposition to aneurysm, and then later in your life, when you get to be like old, like me, and you develop a little hypertension, then it starts to bulge a little bit. Maybe the weakness is there, but it hasn't been tested. So it starts to bulge and bulge and bulge, and you've got hypertension, and it gets higher and higher, and it starts bulging more and more, and then it can rupture. Now if it ruptures, now it's a hemorrhagic stroke. Okay, so you can have an aneurysm that doesn't rupture, and that can be an hemorrhagic stroke. You can also have a vessel that ruptures that didn't have any aneurysm on it. It just ruptured for another reason, maybe because of some cocaine. Cigarette smoking and hypertension are the greatest risks. I mean, you have the congenital defect once again, so you need that congenital defect, but you add some cigarette smoking and hypertension onto it, you're at much higher risk for it to start bulging and to rupture. If it's larger than 10 millimeters, if there's a 50% chance per year that it will rupture. 10 millimeters is pretty big in the head. That's a pretty, 10 millimeters is not very big in general, but it's a big space to be in the head. So usually by the time it gets to 10 millimeters, even if it hasn't ruptured, you might be having some symptoms. depending on where it is, you're going to have headaches, or my vision's kind of blurry, or my arm's kind of weak. So it may be TIA symptoms, but they do some scans and realize, oh, we've got an aneurysm.
What would they do if they actually?
So if you find an aneurysm that hasn't ruptured, or sometimes what happens, someone comes in with a ruptured aneurysm, and in the course we're treating them for that ruptured aneurysm, we find 3 other aneurysms that they have in their brain that haven't ruptured. So there are varying degrees of things that they can do, depending on how big it is. If it has ruptured, we need to address it. But if it's small and it's in an area that's difficult to get you, we can do a wait and see kind of thing and do a cerebral angiogram every year. You can go in and surgically clip it. Most aneurysms are what we call berry aneurysms. So they come off, and I guess this is a decent little representation. They have like a little neck and then kind of a balloon. So you can think of like a balloon coming off, where there's a neck of it. There's an area that you could get in there and squeeze. So they'll actually manually clip it with they're not metal, but some kind of biologically kind material to clip the neck of the aneurysm. So you can clip it. You can coil it, where they can thread in a platinum coil using angiography and thread a coil into there and fill it up with this platinum coil that clots it off and keeps it from rupturing. There's a glue that they can use and squirt in there that will actually just make a glued up chunk. So very depending on where it is, the severity, etc., there are ways that we can address it. But of course, the easier it is to get to surgically, the easier it is to try and treat.
Hey, Julie,
Yes.
do they eventually remove it, or do they just?
Once it's clipped or clotted off, then it's kind of inert. It just hangs out in there. It's taking up a little bit of space, but it's usually not going to rupture anymore. But especially with the coiling, when you're trying to get that coil in there, we know that there's a chance of rupturing it as you're trying to get the coil in there. So they're always ready, like, we're doing a coiling procedure. We're anticipating, hoping that it's just going to be, we're going to coil them, get them out, but they've got the rest of the neurosurgical team ready to go in case they have to do, like, open everything up.
Julie?
Mm-hmm.
So it's like you can only be born with it, and like smoking and hypertension will make it worse. But
Right.
like, you can smoke and have hypertension, but if you were never born with an aneurysm, it makes sense.
Exactly. So it's a congenital malformation that you kind of need to think, there's a lot of other things. You need like this genetic issue along with environmental things going on. So you might have a couple of, weak areas in your vessels, but you don't smoke and don't have hypertension, and they never actually bulge because you haven't tested in a weak area, essentially. Yes?
We talked about a medication last week, calcium channel blockers. It's
Uh-huh.
called Nimtob.
Nemtop, yes.
So would you take that every day, or when you realize every night?
So we're going to talk about with this aneurysm. So I mean, if you know you're hypertensive, we're going to follow the normal hypertensive rules as far as which medications you should be on. But with, so ruptured aneurysm is what we're going to talk about here. So if the aneurysm hasn't ruptured, we're just going to potentially treat it surgically, control other risk factors like hypertension, and depending on how big it is, wait and see. So a ruptured aneurysm, when that occurs, we have bleeding into the subarachnoid space. This tends to occur in a little bit younger of a population, the most frequently between 30 and 60 years of age. And there's a high morbidity and mortality. Mortality is death, morbidity is long-term injury. Only about a third of the people who experience one of these ruptured aneurysms will survive long-term without major disabilities. I think, don't quote me on this, so this won't be on the test, but I think about a third die pretty quickly, another third are left with some significant long-term disabilities, and then we have our lucky third that managed to get out. It was really great too. I should put this up for you guys. So UIH is a comprehensive stroke center, and we had, I will never forget this girl because it was a very compelling story. Young, healthy, no comorbidities, in her 20s, was working out at the gym and collapsed. Turns out she had an aneurysm that she never knew about. She was exerting herself, probably blood pressure going up, huge brain bleed. When we had her in the hospital, it was shortly after the bleed. My students took care of her, and it was, she was kind of alert, but she was looking around. She wasn't very verbal. She was very confused, didn't recognize a lot of people, couldn't move a lot of her body. And one of the students who cared for her a couple years ago actually just sent me a YouTube video that UIH had developed in conjunction with their brain aneurysm program, interviewing her and talking about the process of her recovery. And she looks amazing. She still has some minor issues with one of her legs being weak. But it's really nice too, especially those of you who will maybe work in neuro, that we do get a very skewed idea as well, because brain injuries can take a really long time to evolve and heal, and intensive therapy can really help. So I'm going to try and find, just if you're interested, I'll put it on the Blackboard site. It was only a couple-minute video, but kind of talking about her, and it's just like, oh my gosh, I remember her, and it's so nice to see someone who's come out so well afterward. But I digress. Let's see here. Okay, ruptured aneurysm, intense headache, worst headache of your life. Sometimes they call it a thunderclap headache because you have a big blood vessel that ruptures, and it's like all of a sudden I go from, hey, I'm feeling great, to, oh my God, my head hurts so bad. Blood in the subarachnoid space irritates the meninges. So you're going to get some symptoms of meningeal irritation. And some of those big ones are nuchal rigidity or stiffness of the neck, because you've got meninges lining the sides of the spinal cord. Whenever I do this, my meninges are sliding around back and forth because it's also in my vertebral area, right? When your meninges aren't irritated, you can move your head around all you want, and your neck will hopefully not work, or not hurt. It will work. Hopefully it will not hurt. But you have stiffness because it hurts. And then also photophobia, because you have meninges lining the optic nerve as it's going back to the occipital lobe. So it's going to cause some, oh God, the light is so bright. Cranial nerve deficits, including things like diplopia, blurred vision. As it progresses, we're going to start to see some loss of consciousness and increase in the cranial pressure. Interesting, 50% with a rupture, if you're able to talk to them later, they're going to say, yeah, I really was kind of experiencing headaches more frequently in the days and weeks leading up to the rupture. So it was bulging more and pushing more, and they were getting more headaches. But I don't know about you guys, I get headaches fairly frequently, so when you get a headache, you pop, for me, a couple Excedrin, wait for it to go away, and you just chalk it up to stress or life or whatever. So it's a really easy thing to write off, though. But sometimes, looking back, hindsight is 20/20. It's like, yeah, okay, maybe I should have paid more attention to that. So something very specific to ruptured aneurysms is something called vasospasms. And this is really scary. This is part of the reason why there's just such a high morbidity and mortality. Usually happens, the highest rate is about 3 to 10 days after the initial bleed. And the underlying mechanism is not completely understood. But what happens is the vessels that are leading into the area where the aneurysm ruptures start to severely spasm. Sometimes spasming so severely it's like having another stroke. And I've seen people who have lived through an initial ruptured aneurysm and then afterwards have a vasospasm so severe that that's what killed them. This is another reason why someone who has had a ruptured aneurysm, even if they have a really good recovery initially, they'll often keep them in the ICU for the first 2 weeks to monitor them. So I've seen these really, in general, healthy looking people, with one side of their head shaved, sitting in the neuro ICU where the rest of the patients are intubated with bolts coming out of their intracranial cavity and not moving. Just kind of sitting there because they've had a ruptured aneurysm and we know they might have vasospasm. So we want those neuro nurses to be, doing a complete neuro check every 1 hour so they can pick up the tiniest change. Some pharmacologic treatments, nimodipine or verapamil, both calcium channel blockers, has been shown to reduce the incidence and the severity, but not completely stop it. And also milrinone is another medication. No need to worry too much about milrinone, but it's just know that there are some medications that we're working to try and treat it, but they're not 100%. All right, AVM or arteriovenous malformation. I talked a little bit about it earlier. It is abnormal arteries and veins that are linked by fistulas. Now, normally you have an artery and it goes down to some larger arteries, down to arterioles, and then feeding into a capillary bed. And the capillary bed's a very low pressure system. And we've got exchange of nutrients going on. And at the other end of the capillary bed, you have the venous side. And on the venous side, you don't have that nice muscular, thick layer on that side. But it's okay because that capillary beds create kind of a buffer. And it's decreased the pressure. So by the time we get to the venous side, we have a nice low pressure system. So this is a problem with embryonic development. Once again, you can't just spontaneously develop an AVM, although you may not know about it until it ruptures. But it's this tangle of arteries and veins, arteries dumping directly into the venous side without a capillary bed. Okay? It will worsen with age, especially if someone is hypertensive and you're putting more pressure in that area. And interestingly, 70% of people with AVMs have a learning disability. So even though we don't have necessarily early warning signs, we also have this hindsight being 20/20. And we'll talk a little bit about why that's going on in the next slide, I believe. Yes. Okay, so the two big problems with this is that number one, you've got the blood going from a higher pressure arterial side to a low pressure venous side without that buffer of the capillary bed. That venous side cannot handle that kind of pressure for a really long time, especially if you add any type of hypertension to it, okay? So you don't have it starts to bulge, and sometimes the first sign that you know you have an AVM is that it ruptures and you have a massive intracranial bleed. Sometimes we can catch it earlier. I'm starting to have headaches, I don't know why, I'm having these weird symptoms. As it starts to bulge, we go, oh, you've got an AVM, they can go in there and fix it up. That's the best case scenario. There's also the idea of vascular steal. So however much blood is going into the vessel, the arterial side of the AVM, is passing straight from that arterial side to a venous side without ever exchanging nutrients. And that means, depending on how big that vessel is that the AVM is formed out of, a portion of the blood that's going up to the central nervous system is going in and out without ever exchanging nutrients. That's called vascular steal. They're stealing the blood away without dropping anything off, any of the good stuff off. So this is theoretically why we have a much higher incidence than the regular population of learning disabilities in people with AVMs. They've just throughout their entire life had a little bit less blood being able to be delivered adequately to their brain. All right, so now we're going to talk about in general. This can happen with a stroke, this can happen with a ruptured AVM, a ruptured aneurysm. When we have disabilities or problems with blood flow, what are some of the kinds of things, the kind of disabilities we'll see in our patients? So if our motor cortex is damaged, we can see weakness on the contralateral side. It could be total paralysis as well. Clumsiness, loss of fine motor skills, tendency towards foot drop and edema in the limbs affected. You guys you guys heard about foot drop, right? If you don't stretch out that Achilles by walking, it's going to start pointing. Corticospinal tract, if that's affected. Initial flaccidity, then spasticity, so we see contractures. So this is an upper motor neuron. We're talking somewhere between the motor cortex and where it exits the spinal cord, and that's when we start to see those contractures develop. Have you guys seen patients with contractures yet? Yeah, some of you probably have. Because this can happen in a motor vehicle accident, cerebral palsy, those flexors that are flexing more than the extensors are, and the contractures that can develop. Dysarthria. Dysarthria is the name for impaired articulation with speaking. So this is not an issue with Wernicke's or Broca's areas. This is an issue with the motor areas that control the mouth and the tongue. Now, if you look back on the motor and sensory homunculus, you can just see how much of the motor cortex, compared to how big the mouth is compared to the rest of the body, space is dedicated to that. Because just to talk and to chew and to do all the things that our mouths do, you need a lot of motor control. So you can have intact ability to understand, intact ability to get your sentences out up to the point where your mouth gets like this, right? So if you don't have full control of your tongue or your lips, it might come out jarbled. So the content of the speech, their ability to understand is fine. Just sometimes it's hard for us to understand them because they're not speaking clearly. Then we have aphasia. which is when we actually have some of those areas that help us to understand and get speech out are affected. So Wernicke's aphasia, an ability to comprehend the speech of others and of themselves, and the inability to read. Now there can be varying severities. It's not all or nothing. If only part of Wernicke's area is affected, you might have a harder time with comprehension, but can still get some basic ideas or big picture stuff. Anomic aphasia, the name is nearly normal, but problems finding individual words. I have that all the time, so I don't think that's really a deficit. Conjunction aphasia is an appropriate word use, impaired words and word substitutions or impaired repetition. You'll see a lot in a neuro unit where you'll come in, you'll see a neurologist or a psychologist saying, okay, repeat after me, and have a sentence that they want the patient to repeat back. Pretty easy for most people to do when they don't have brain damage, but when you have destruction of the fibers between Wernicke's and Broca's areas, even though they're kind of in two different areas that do two different things, they work together. So they might be able to understand things pretty well, be able to get things out pretty well, but there's little parts of speech that just aren't 100%. And then expressive aphasia is damage to Broca's areas. If it's severe, once again, we can have variations depending on how much of Broca's area is damaged. But if it's severe, the speech is very limiting, single words only if they're lucky, and they also can't write if it's severe. So all ability, all language processing is gone. And this especially is very, very depressing and isolating for the patient because they have no way of getting anything across to other people. They can't write it out, they can't speak it.
They can't sign language?
Sign language sometimes can, sometimes not. Something else that we'll do is sign boards, where it's like a picture of someone sitting in a toilet for us to know, if they can point to that and be like, okay, pictures I can get. So we have done that with some of our patients as well. But this in particular, not being able to express yourself or just convey basic needs, especially when you've had a huge stroke and you probably have a lot of other symptoms, very isolating. Denial or heavy attention is just a fascinating phenomenon. This occurs when there's injury in areas of the brain that interpret incoming sensory information, and it will lead the patient to deny one half of the body or one half of the environment. Their brain just does not recognize that there's another half of their body. It's usually a half of their body that is not feeling anything, that has lost sensation, sometimes motor, and one half of their environment. Some strange things that you'll see with patients who have this. You'll ask them to draw themselves, and they'll only draw like a half of a body. You put a piece of plate or a plate of food down in front of them, and they'll only eat the food on half of the plate. But then if you rotate the plate, they'll eat the food on the other half of the plate. There's ways, and I'm not involved in brain rehab. I'm more of the acute care, keep them alive, and get them out to rehab as quickly as possible. I know that there are ways to work with patients in long-term rehab settings that can help them to recognize, oh yes, I do have another half of my face. Because patients will they'll go look in the mirror, shave, and only shave half their face. Really fascinating, and they tend to not really they don't understand. It's not like, oh my gosh, I can't believe I forgot half my body. It's just to them, it's not there. Oh, you don't really have to worry too much about homonymous hemianopsia beyond the fact that, what is this funny word? So if you ever see it in charting, it has something to do with the eyes. The motor, you guys remember having to kind of trace out the pathway of all the optic nerves and how, one from one side will go over this way, then they'll cross off and branch at the optic chiasm. Because it's so crazy in there. You can have some very strange things that occur in vision depending on where you have a stroke or a tumor or something else going on. So for example, if I have a stroke that affects a couple of fibers up here, it's the lower right optic radiations, this is what my vision will look like. The areas that are in blue, I will not have the ability to see. If I have a stroke right here, right behind one eye, I will only be able to see the inner portions of my field of vision. So I'll only be able to see like this. You'll see a little bit here. So you don't need to memorize any of this except know, homonymous hemianopsia, that means there's all these different places along the optic path that there can be damage. You can get a whole bunch of really weird types of vision. Alright. Trauma, infection, and tumors. Well, I think we'll get through most of it. All right, traumatic brain injury. We can go on and on about traumatic brain injury, and there's so much new stuff coming out about TBIs, especially in relation to football or other repetitive head injuries in contact sports. Learning more that even people who just played for a couple years in high school and never even went to college to play football will still have potentially some damage. So anyone out there who did some contact sports, I'm sorry. You're screwed. No, you're not. Obviously, the longer you play, the more intensive hits you get, like in the NFL, you can have some issues. But a lot of others, I mean, hockey. In women, girls soccer is actually really high rate of head injury, and that surprised me too, because as a neuro nurse, I'm thinking like, oh, what are all the safe things I can get my daughter into where she's not going to break her head? My husband's like, let's get her into hockey. I'm like, no. And yeah, so I'm like, oh yeah, soccer, you're just kicking a ball around with your feet, and apparently you get a lot of head injuries too, running into people and doing the headers with your forehead. So I digress. There's an estimated 7 to 10 million traumatic brain injuries each year. And there's a big part of estimation because there's a lot of people who get smacked on the head really hard and don't get follow-up. Like, oh, well, you know, he only passed out for a couple minutes, he's fine, get him up. And the reason I say he is because it's 15 to 24-year-old males who are the highest risk because testosterone makes you dumb. And do really stupid things, you know, when the testosterone really kicks in before, and it really is, it's actually, I mean, the 24 years old is the age when the male brain is fully adulted. Women a little earlier, girls a little earlier. So it's kind of like, you know, here's like the testosterone kicks in, but your frontal lobe isn't quite there yet. You start doing all the really crazy, stupid stuff. And then like people are like, oh, wait a minute, let me put on a helmet. 50,000 deaths annually, many of them preventable by things like wearing a helmet if you're riding a motorcycle or a bike, or putting on a seatbelt and not drinking and driving and not speeding and driving in safe conditions and all that good stuff. So skull fractures, just some definitions of different types of skull fractures. You can have a simple or linear skull fracture, which is a break in the continuity of the bone. A comminuted fracture, which is a splinter or multiple fractures. A comminuted one can also be depressed, meaning that instead of having the nice round shape, that part of the skull is pushed in which we can have bone fragments that embed in brain tissue, which is never a good thing. And then just to differentiate, a basilar fracture is seen is at the base of the skull, can be linear, can be comminuted, can be depressed, but the base of the skull down here, so if you fall back and hit your head, or you get whacked in the back of the head with a golf club, you'll frequently see cerebrospinal fluid leaking from the nose or the ear. Because the base of the skull here, the very inside of the nose, and the inside of the cribriform plate, even though I'm coming at all these different directions, they're very close together in the center of the brain, or the center of the skull. And the way we differentiate, you know, is it snot or is it not? When someone comes in with, you know, a head injury and runny nose, is testing for glucose. Because snot does not have glucose in it, but cerebrospinal fluid does. You can just take one of those urine dipsticks that we test, you know, those different color squares. Or you can do it using the Accu-Check machine and put some of the fluid on the Accu-Check machine too. Would only be doing this probably if you were working in the ER or out in the field. So when we're looking at brain injury, we have our primary injury, which is our initial concussion, contusion, laceration. It's the thing that happened. But then, because of all the things we talked about last week with excitotoxicity and increase in cranial pressure and cerebral edema and too much calcium, those are things that are going to keep damaging the cells unless we stop things from happening, okay? So if we maybe can't stop the fact that our patient comes in after a car accident where they were thrown, ejected from the window and landed on their forehead. But we can potentially help with the things like preventing the intracranial pressure from increasing too much by getting them to the OR quickly to remove a portion of their skull to relieve pressure. So We can do some prevention stuff with primary, but once our patient comes to us with an injury, what we're really focusing on is preventing ischemia, increasing the cranial pressure, cerebral edema, and herniation. All that stuff we talked about last week. Yes?
This is kind of off topic, but when they remove a piece of your skull if you have high intracranial pressure, do they put it back or do you just...
Well, that's a great question. Okay, so they remove part of the skull, they do this hemicraniectomy. Where do they put it? Well, it depends on what shape it's in. Now, if it's been like shattered, if you guys are interested in traumatic brain injury, oh God, what was Bob Woodruff? Is that his name? He was a, well, two for you to look at regarding a traumatic brain injury. Bob Woodruff, and Gabby Giffords. So Bob Woodruff was a reporter for NBC, was embedded with some troops in Iraq, got hit by an explosion on the side of the head, and it just like shattered one side of his skull. Both with him and with Gabby Giffords, which you may recall, she was a congresswoman from Arizona who was shot at a campaign thing in Arizona. Both of their families were willing to talk on TV, and actually in the case of Gabby Giffords, they had a lot of video camera videos that they had taken in the process of her recovery, including part of her therapies sessions. And both of those were on, the stories were on Dateline NBC or 2020 or something. So those are other things that I'll put on for you guys. I'll track them down and find them if you're interested in watching some of this. So if it's just like shattered little pieces, then we're like, okay, well, there's not really anything we can do to save that. They can do a scan of the actual hole for that skull and then create a new plate. It used to be titanium, but they just put a titanium plate over it. But those people would like be able to pick up radio stations in their heads. They had metal, and they said, "No, I'm serious." And then they set off metal detectors and everything. So they started using some kind of plastic composite that they put in there. But if it's a more controlled setting, someone who has a massive hemorrhagic stroke, it's not a shattering of their skull. They can take out this chunk of skull, this piece of their cranium. Where the best place to put it is actually in a little pocket inside of the abdominal wall. They'll make into the subcutaneous tissue area. So they'll make an incision, kind of hollow out a little pocket, put it in there, sew it back up. So if you were to palpate their abdomen, it's like, oh, abdomen, thunk, 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 skull. Don't want to give a heparin injection there. So the bone flap, they call it, is sitting in their abdomen. And it's just keeping it nice and healthy and warm and nutriented until it's time to put it back on. Yes?
Can you see it?
Yeah, it depends on how much subcutaneous tissue the patient has. On a thinner patient, you can see, I gotta find you guys just a whole bunch of pictures. You'll see, on a thinner person, you'll see the incision and then a bulge. And someone who's a little bigger, you might see the incision, but not really be able to see it, but you can feel it. So maybe it's about that big, sometimes they're smaller ones too. It depends on how much they need to remove. If they can't put it into the abdominal cavity for whatever reason, they can store it in the blood bank of the hospital in a special solution that keeps it happy and warm and full of nutrients until it's time to go back in. Always a risk of infection. We've definitely had patients who we save their bone flap, we put it back in, they develop an infection, MRSA, in the bone flap. You need to take the bone flap out, at least 6 weeks of antibiotics, and then we've got to toss that bone flap. And then that's when they get a prosthetic one. Great questions. Okay, so we're definitely not going to even finish today. I'll pick up right here next Monday because my tongue won't work anymore. It is, I agree.